Welcome everyone. Thank you for joining us today. I am Bansi Sutariya, internal medicine resident. Today I'm delighted to have Dr. Chukwudike, who is renowned gastroenterologist and hepatologist at Caliber Hospital, Nigeria. So thank you for being here today, doctor. Can you please share with us your introduction and your experience of working at Caliber Hospital?
Thank you. Good day, everyone. My name is Dr. Evaristus Chukwudike. I'm a consultant gastroenterologist and hepatologist. I was at the University of Calabar teaching hospital for 14 years. I did my residency training at the University of, I actually did my medical school at the University of Calabar and progressed to residency training at the same university after doing my composite 1 year housemanship at the Federal Medical Center, Abakaliki in Ebonyi State. So I returned to University of Calabar for my residency program. In the course of doing my residency program, I proceeded to World Gastroenterology Training Center, where I obtained the scholar fellowship as a scholar at the World Gastroenterology Training Center. During that time, I returned to University of Calabar and completed my residency training program. And as I was completing my residency program, I got American College of Gastroenterology International Training Grant on gastroenterology to travel to United States. I went to Rhode Island Hospital, Brown University, and the Upper Medical School, where I had fellowship for 6 months. That program, I finished the program with distinction. I returned again to University of Calabar and got appointment as a consultant, a gastroenterologist and hepatologist, where I was working. I've been working until about 3 weeks ago, when I had a call to carry out a program at the Radio Center for Digestive Health, located in Lagos, Nigeria. Prior to that, I went to India at the Manipal Academy of Higher Education. I did an advanced program, hands-on program in ERCP and EUS. Then returned to Nigeria to start my work. And that's the journey so far.
So thank you for sharing your journey with us today. So could you share with us what inspired you to specialize in GI and hepatology?
Thank you. So as a trainee, I saw the burden of gastroenterology-related diseases, and I also saw what our people are going through, the challenges of managing these patients, the low low gastroenterologist to patient ratio in Nigeria. And again, looking at the burden of hepatitis, viral hepatitis in Nigeria, we have high prevalence of hepatitis B infection, as well as hepatitis C infection. Nigeria is the most populous country in Africa, with a population of over 20 million. The last study on viral hepatitis in Nigeria showed that the prevalence of viral hepatitis B infection in Nigeria is 8.1%, and that of hepatitis C is 1.1%. Cumulatively, when you put these figures together, Nigeria has over 60 million of its population having hepatitis B, and over having hepatitis C infection. So putting together, over 20 million of our population have suffering from viral hepatitis. Many of them progress. Many of them don't even know. Over 90% of people that are infected don't even know they have viral hepatitis. So a good number of them will progress to chronic liver disease. Some of them will progress to liver fibrosis, liver cirrhosis, and then a good fraction will progress to liver cancer. It is so bad that many of our patients come when they are, the reason why they are coming for the first time to hospital is when they have decompensation. Liver is already decompensated. And what brings them is this severe abdominal pain and the mass in the right upper part of the abdomen. When they are presenting to the hospital for the first time, it's liver cancer, hepatocellular carcinoma. So all these were what made me choose gastroenterology as a specialty to help my people and see how to reduce the burden of liver disease among Nigerians.
So you mentioned that prevalence of hepatitis is very high in Nigeria. So what other GI diseases do you see in that specific area?
Oh, thank you. So the viral GI diseases we see, we have a very high burden of Helicobacter pylori. Mm-hmm. Nigeria is the country that has the highest prevalence of Helicobacter pylori. Studies have shown that H. pylori prevalence in Nigeria ranges from variable at different areas, but when you put it together, it ranges from 73 to 87%. So so many people come with abdominal symptoms. See people with epigastric pain, heartburn. Some of them have these challenges, bloating, flatulence. So when you get to the other side of it in the liver, a good number of people present with liver because of viral hepatitis. We see so many people in Nigeria coming down with liver cirrhosis and liver cancer. In fact, there was a study done in Nigeria that showed that the most common cancer in our medical world is hepatocellular carcinoma, such that about 12% of people occupying our hospital internal medicine medical ward beds, about 12% of those people are people infected with liver, people having burden of liver disease. So we have pancreatic cancer, biliary disorders. So there are various diseases we have. Before in Nigeria, we were thinking that inflammatory bowel disease was not a big problem, partly because we were not doing a lot of evaluation, a lot of screening, colonoscopy, a lot of evaluation for these people. So, but now the reality is that we have inflammatory bowel disease in our environment, though not as high as what we see in Western world, but is becoming a very common diagnosis in our own environment. People come to the hospital with irritable bowel syndrome, presenting to the hospital for evaluation. I mentioned about the pancreatic cancer because we didn't have advanced endoscopy. It was not really in our environment. So so many things and so many of the diseases, biliary disease, gallbladder disease, and pancreatic disease were not being given prominence, though they are there, but not much is being done about that. But right now, we're now having advanced endoscopy. We're now seeing these people are being diagnosed and treated. We're now seeing many people, this disease is surfacing in Nigeria more than what we thought would be. And then because of the colonoscopy and endoscopy, the scales coming up in endoscopy, many of these diseases are being diagnosed and being treated.
Thank you for answering that question, doctor. So my next question is, how often do you encounter the patients with liver cirrhosis and how do you work them up for liver transplant? And also, what are some transplant centers that you would prefer sending your patients to?
Thank you. So for our patient, the evaluation of our patient with liver disease for transplant, we see a good number of patients coming with liver cirrhosis. The reason being that our presentation, most of our patients present late. And so the viral hepatitis, our patient with viral hepatitis, studies have shown that over 90 to 95% of people who were infected with hepatitis B and C, hepatitis B, and who go through vertical transmission or perinatal stage, a good number of them will progress over 90% will progress to chronic hepatitis. Unlike people who are infected at the adult age, that less than 10% will be infected, will progress to chronic hepatitis. But most of our people are actually infected at the vertical level and prenatal transmission stage. So they progress to chronic hepatitis. But because symptoms are not actually shown at that early phase, we know what happens in hepatitis B. When patient going through all the stages, immunotolerant phase and all that at the childhood. So symptoms are not there. And patients grow like that, develop symptoms like malaria, all the tiredness. They think they have malaria because malaria is a common problem in the environment. Then they go and treat malaria and then remain like that. This is the time hepatitis B progresses to the liver and then keeps gradually destroying because of what we call cytopathic effect of the virus on the liver. Gradually, the liver is being destroyed, and over time, by the time they are presenting, they present late, and they're presenting with a good number with liver cirrhosis. So when we see this patient, this typical Nigerian patient with liver cirrhosis coming to the hospital with abdominal swelling, leg swelling, yellowness of the eyes, we do try to do evaluation. We look at the liver function test for them. We check, first and foremost, we start to diagnose them. We now see that they have hepatitis B or hepatitis C. We need to do the evaluation for hepatitis, serological profile, liver function test, hepatitis B, the DNA quantification. We try to type, with that, we try to grade them where they belong in this disease. We look at those people, and now look at, of course, they have to get imaging, abdominal ultrasound scan, then CT scan for some of them who are suspecting of liver cancer. And once we do all this evaluation for them, of course, the metabolic panel will also be done, check all this. By the time we look at them and we grade them and see that these people are candidates for liver transplantation, beyond at that point, we cannot reverse their illness where they need liver transplantation. We don't have a liver transplant center in Nigeria. There's none right now, though effort is being made to establish one. In the meeting we had with the President of the Federal Government of Nigeria, we also had that meeting in Nairobi, where I had a program, African Pancreaticobillar Cancer Consortium. We had a meeting last year in Nairobi, where countries that have been doing transplants, like Egypt, South Africa, those countries were there in that program, and we had a meeting with them, with the representative from Nigeria, on how to support Nigeria so that we can start liver transplant program. And that program is gradually getting steam. So we're hoping that Nigeria, there will be transplant. But as of today, any Nigeria that has liver cancer or advanced liver disease, competitive liver disease, or that needs transplant for any reason, we have to go out of the country. Some will travel to India. India is one of the good places they travel to because of the cost differential in transplanting our patients. Some will get to South Africa, Egypt, and any other country of the world. So this is where we are on liver transplantation in our country.
Okay. Thank you for giving us a brief idea about that, doctor. So how do you think the rising rates of obesity and dietary changes are influencing the prevalence of gastrointestinal diseases?
Great. So that's another area that we initially see obesity is a risk factor for liver disease. We see our patients with obesity, with diabetes, with dyslipidemia, progressing to fatty liver. Before, somebody would do ultrasound scan in Nigeria some years back, fatty liver, just drop it. But now we know that fatty liver also progresses just like viral hepatitis. Patient progress to from fatty liver to non-alcoholic steatohepatitis, fibrosis to cirrhosis to liver cancer. So it is a burden in our environment now that our people have adopted westernized diet. So the prevalence of obesity is rising in our environment. And as prevalence of obesity is rising in our environment, our patients are also having a chunk of liver-associated, obesity-associated liver disease in our population. So it is a big challenge in our own environment. We have, say you have an alcoholic fatty liver disease. Alcohol is a problem, but not like where alcohol is, the position alcohol is taken in the Western world. Alcohol is down in our environment. You have viral hepatitis, NASH, before alcohol will come in as a risk factor for liver disease. It's a common risk factor for liver disease in our environment. So this is a problem in our environment, and we are trying to grapple with it and trying to sensitize our patients and to know that our people to know that obesity is a problem, as well as alcoholic liver disease and diabetes and all that is factors for liver disease.
Okay, thank you for sharing that with us, doctors. So you mentioned that you see a lot of patients with decompensated or late-stage liver disease. So what are some screening tests that you would recommend for early detection of those diseases?
Good. So for our environment, where viral hepatitis is the major driver of liver disease in Nigeria, we try to do for our patients. We have keyed into the World Health Organization guideline and sensitization that is ongoing in coping out viral hepatitis. So July 28, 29, we try as much as possible to have programs that run for a few days, some for weeks, to sensitize our people apart from what we do every day, to sensitize our people on the need to get screened for viral hepatitis. We ask our patients to get hepatitis B surface antigen, at least for basic screening, that everybody should be screened, at least do hepatitis B and then do also hepatitis C virus screening, so that we'll be able to pick out those that are infected. All these 8.1% for hepatitis B and 1.1% for hepatitis C, they are in the population. They're in the population that move on every day. So we try to screen them, because if you can screen them and get to diagnose them of having hepatitis B or C, good enough. Right now, hepatitis C is curable with the newer drugs that are available. The direct acting antiretroviral and acting therapy that is available, we can diagnose and cure hepatitis C, which we do in Nigeria today. Hepatitis B, though there's no drug for cure right now, but all these drugs are effective in bringing down the load of the virus and even making it undetected in the blood. Because one of the factors that will potentiate somebody developing from hepatitis B to liver cancer, liver progression to liver cancer, is one of these, like the high viral load, hepatitis B viral load. So these drugs have the ability to bring down the load of the virus. Some will get it undetectable in the blood, but we don't tell them that they are cured, because we know there is what we know as close covalent DNA that is in the liver. So even when we don't detect it in the blood, we don't tell the person that it's been cured. And we try to tell them so that they will not work with people that are not trained, that will tell them, okay, because you did viral load and the viral load is undetected in the blood, oh, you are cured. That's erroneous, because this patient can also progress, bounce back, reactivate, and progress to liver cancer or even liver cirrhosis. So we screen them for this, for viral hepatitis, and even blood transfusion. Now in Nigeria, there's no place anybody will transfuse blood, at least to the best of my knowledge, that hepatitis will not be screened, even hepatitis B surface antigen, which is not even enough. Most of the centers have progressed to screening both for surface antigen, the serological markers. We do the serological markers. We look at the hepatitis B surface antigen. We look at the core antibodies. We look at the envelope antibodies. We try to look at all these before you transfuse blood, because there is this concept of occult hepatitis. So even the hepatitis B surface antigen is not positive in the blood. It could also, the person could also have, it's still possible that someone has hepatitis B infection, but the surface antigen negative. So it's good for, especially when you transfuse, where it becomes very important, when this such blood that is hepatitis B surface antigen negative, it transfused to somebody that is immunocompromised, the risk of these people developing hepatitis is there. So these are screening techniques we try to adopt to evaluate our people for hepatitis, so in order to curb the liver disease in Nigeria.
Okay, thank you for answering that question, doctor. So what resources would you recommend for the patients with inflammatory bowel disease, particularly for managing emotional and psychological aspects of the disease?
Thank you. So we, as I said earlier, that inflammatory bowel disease is now gaining traction in Nigeria with the effort being made to have enough diagnostic facilities in our country. So as we see people with inflammatory bowel disease, Crohn's disease, ulcerative colitis, or the disease itself is a chronic disease, we know, and it has a toll on anybody that is infected. A good number of patients, some of them keep having a stream of blood, some of them keep stooling over and over, and sometimes they even think that it was somebody has somebody is the cause of their problem. It could be charm, it could be some fetish or the other. They'll try to let them know that this is a disease. So we try to encourage them to first come to the hospital. Once diagnosed, we don't have organized IBD club, IBD community group in Nigeria, but we try to make sure that we have close contact with them, trying to manage the emotional support. We also refer them to counseling units that we have available in our hospitals to talk with them, and then we follow them up in order for them to because counseling is very important, especially in this era of patient-centered care. We really need to counsel them. It will impact on their emotional well-being, their ability to continue to assess a treatment, to follow up the care is higher when we counsel them, when they understand that that doctor and all the health workers are really concerned about their illness. So we try as much as possible to follow them emotionally and also support them. But the challenge of managing it is high in Nigeria, because what we have in most of our hospitals is this out-of-pocket payments. Patients have to pay for whatever the care they get from the hospital. Only about 5% of Nigerians have national insurance, health insurance scheme. So it makes it very difficult for patients to continue to follow treatment. Well, most of the drugs we use for inflammatory bowel disease, and they are not cheap. They are very expensive drugs. So when the patient is willing to continue, over time, the patient will be resource-wise, patient will be drained, and they'll see many of them drop off. So these are the challenges and how we go about helping them to solve the problems.
Okay, thank you for answering that question, doctor. So our platform, Global Gastroenterology, is about educating general population about various GI diseases, screening techniques, and preventive measures. So for the population, like what symptoms should prompt someone to see a GI doctor?
Okay, so for our population, Nigerians in particular, and other parts, which is the same thing that we see other parts of Africa, actually, it's not quite different. So I'm talking about Nigeria, I'm actually extending to other parts of the country. I've gone to so many places in Africa. This gastroenterology program, Rwanda, Ghana, Nigeria, Kenya, and all that, South Africa, and all that. So it's relatively the same, especially in sub-Saharan Africa. So if one has, you have heartburn, abdominal pain, epigastric pain, or any abdominal pain, right-sided abdominal pain, or any abdominal pain, you have yellowness of the eyes, you feel anorexic, you know you used to eat very well. Now you see food, you're looking at it, you don't even understand what is happening. You need to see a doctor. Yes, we don't have so many gastroenterologists everywhere in Nigeria, but you need to see a doctor who will review you, and the doctor might start you on treatment at the primary care level. If you are not getting better, the doctor will escalate the treatment to see a gastroenterologist so that the patient will be evaluated. So some of our patients have leg swelling. They think it is because somebody has charmed them, put charm for them. So they're not even thinking about it. There's a disease that can cause it. So abdominal swelling, somebody remains at home, they're putting a scratch mark on the abdomen and thinking that they are solving the problem until it gets out of hand. Some of them will come to the hospital. Some of them come in fact, as they live in the place where they're being taken care of in the herbal homes. Some of them get to the hospital and die the same day because they were almost dead before they were pushed out of where they were. So we encourage our people, when you see any of these symptoms, come to the hospital. But beyond waiting to see some of these symptoms, you can, it's always said that prevention is better than cure. Whether you are sick or not sick, because most of the people that have viral hepatitis do not know they have it because symptoms don't show readily at the early time. So if you have viral, you can go and screen yourself. There's also what we call colorectal cancer screening. Don't wait until you begin to have weight loss, abdominal pain, or you have begin to pass blood in stool before you think of doing colonoscopy. Any Nigerian that is below 40 years, because of the concept of early onset of cancer, should go and get screening colonoscopy. The world has prepared to provide it. They don't have to want to get come down with cancer and help people. 35 years, see so many of our people coming out with cancer. Go for screening. Clean yourself from that. We don't have that luxury, don't have that money to manage most of the diseases at the early, when they get advanced stage. So the best time is to cover at the early stage. Then on Helicobacter pylori, Nigeria is the most common country, Nigeria has the most common prevalence of Helicobacter pylori in the whole world. And the only country that is close to Nigeria is Portugal and Estonia. So our people should evaluate themselves for Helicobacter pylori infection. That screening can be done. You check yourself for H. pylori, and if you're having abdominal symptom, gastric pain, heartburn, and you are taking antacid, what is very prevalent in Nigeria is people taking antacid. They keep taking antacid to subdue. It's like just trying to subdue something, and you're not treating it, you're not curing it. So no level of antacid will cure H. pylori. So you need to do H. pylori test and see if you have Helicobacter pylori. And then if you have, we have prescribed treatment. We do triple therapy regimen and progressive, one that is resistant to chemical therapy and all that to make sure that we cure H. pylori. Rather than the person staying at home and thinking that nothing is wrong. Why I say this is that over 80% of people that have H. pylori do not show symptoms. But when we do endoscopy shows that over 75% of people that are infected with H. pylori have signature of H. pylori in the stomach and inflammation of various degree there. So if you wait and say, okay, I don't have any problem, and when the patient progresses to the way H. pylori progresses to intestinal metaplasia, to atrophy, to dysplasia, few of them will progress to dysplasia, and there is a possibility of a fraction progressing to liver cancer, though not like what we see in other parts of the world, but it's possible that there is a possibility that one can progress to liver cancer, despite the African enigma we know.
Okay, thank you for sharing that with us, doctor. So, from your perspective, what key strategies can primary care physicians implement to enhance preventive care in digestive and liver health?
Thank you. So we try to first encourage our doctors, especially at the primary care level, to have high index of suspicion for these diseases. A case in point is one of my patients that had complained of anemia, complained of tiredness and fatigue, and the doctor he was diagnosed to have anemia and then abdominal pain. That patient was transfused over and over. Yet, nobody made effort to actually evaluate what is the cause of the anemia. So this patient stayed with the primary care physician for over 2 years. By the time the patient is presenting to our hospital, he was advanced colorectal cancer. So when we did colonoscopy, we found out he had colorectal cancer and he has already metastasized to the liver. How be it that this patient, at the first time the primary care physician saw and referred the patient up front, we could possibly limit the where it was as at that time. So there should be early referral from our primary care physicians. They should not hold patient too long, and then they should also do continual medical education, because the more you learn, you cannot diagnose what you don't think of, what you don't even have any idea of. Continual medical education to update themselves on the diseases and the treatment and the current strategies of diagnosing all these disorders. Government should come in to support our primary care health physicians. They are doing so much, they are doing so well. But the challenge is that most of our doctors, Nigeria has become a training ground. Breed doctors and they fly out of Nigeria. Most of Nigerian doctors are in the UK, in the United States, in other parts of the world, in Saudi Arabia. Like our workforce is drained. So what we see that the burden is so much on primary healthcare, few that are left, few of the primary healthcare physicians that are left in the country. So government should support our primary healthcare physicians, support doctors entirely, increase their remuneration so that they will be well remunerated, make the work environment conducive, good facilities, because it's not just only remuneration. We need good facilities because satisfaction of a doctor is not beyond pay. When you are treating your patients and you are seeing the outcome of your treatment, which is also a function of the facilities you have to diagnose and the facilities you have to treat. Now, our government should do a lot in supporting our people so that doctors will be retained in Nigeria to care for our people. Otherwise, we'll keep draining our people continue to suffer because of lack of enough doctors to take care of them.
Thank you for answering that question, doctor. I think that will be really helpful for all the primary doctors to enhance and improve the preventive strategies. So what is the one piece of advice that you would like to give to general population about liver or digestive health, diet recommendations, or in regards to preventive care?
So our people should know that digestive disease is a problem. And so the world has recognized it. And that's why you have a day set aside for digestive health to let our people know. And have other days, even still in digestive disease, they are set aside for colorectal cancer. March has been prescribed for colorectal cancer awareness, which we did so much in Nigeria this year. Viral hepatitis, they have been set aside for viral hepatitis awareness. All these things that will show us that digestive disease is a problem. So I will encourage our people to go for early evaluation. Evaluate yourself for hepatitis, especially in Nigeria. If you're up to the age for screening colonoscopy, go for a screening colonoscopy. Know that obesity is a problem. If you are diabetic, know that the handling your diabetes is not just only bringing down your fasting sugar level. Know that you're going to check other parts. Diabetes can also affect other parts of the body. Among them is the liver. You need to evaluate your liver properly. And if you have some of them are people have this lipidemia, there's abnormal lipid cholesterol problem, and nothing is done about that. So know that if you have this, don't throw the result, just say that it doesn't matter. Go for evaluation. All these things, all of them impact the liver. Then for alcoholic liver disease is also a problem, but not at the level of hepatitis. So people should know that significant alcohol intake will predispose them to alcoholic liver disease, which over time will damage their liver, and then some of them will develop cancer from there. Some of them will develop decompensation from there. So people should also know that extra alcohol intake can also make them develop liver cancer, liver diseases, both cirrhotic and decompensated. So all these are areas that people should look out for. And then people should know that abnormal symptoms they are treating and is not going, they should move ahead to a higher center so that they'll be diagnosed and treated properly. Then on diet, people should know that our traditional diet is still a very good one. You know, high fiber diet and what to do, and eating right. Don't eat too late at night and all that. They are very important because our people, some of them eat so late at night, they keep developing abnormal bloating, flatulence, heartburn, especially them that have gastroesophageal reflux disease. It compounds the problem. So our people should know that they should eat right. They should seek help when they realize that there's something going wrong with the digestive system. That will help so much.
Thank you for your suggestions, Doctor. Thank you again for your time and sharing your expertise. It has been a pleasure speaking with you. I appreciate your contributions to the field and for sharing your insights today. Have a wonderful day.
Thank you so much. Bye.